So at this time, I'm going to introduce our topic and our two speakers, and then they will get started in today's presentation. Again, the title of today's presentation is Communicating Vaccine Adoption Based on U.S. Perceptions of COVID-19. And our two speakers are Dr. Lori Baker and Dr. Shelley Rampold. Dr. Baker is an associate professor of agricultural communication in the Department of Agricultural Education and Communication at the University of Florida and conducts research with the UF-IFAS PI Center. Dr. Shelley Rampold is an assistant professor of issues and crisis communications in the Department of Agricultural Leadership, Education, and Communications at the University of Tennessee. And with that, I'm going to turn it over to our speakers. I'll be monitoring the chat session today, and we'll be facilitating that part of the discussion later on. I believe Dr. Baker will be speaking first. Is that right?
Yes, thank you, Dr. Telg. I appreciate that. Dr. Telg gave you a little bit of background on the Ag Safety Center, which is a partnering program with the PI Center, but I wanted to start off to tell you a little bit about the PI Center because it was our work that funded the results we'll be talking about today. The UF-IFAS Center for Public Issues Education in Agriculture and Natural Resources conducts research and educates on how people form and act on opinions regarding complex agricultural and natural resource issues. The PI Center encourages informed decision-making through research, education, and outreach. So what we did here stems from that mission as far as understanding public responses related to COVID-19. We had started this in March 13th through 16th in 2020, very early, just as the pandemic was beginning. And we examined Americans' knowledge, response, concerns, and beliefs related to COVID-19 at that time. And then we conducted survey 2 a little later that year in April and May. We repeated some of those same questions to get a greater understanding of how things had changed. But we also focused that survey on measuring attitudes related to social distancing and wearing masks, because that was the first time that we had really had those issues occur within the United States. And then survey number 3 was even later that year, July 23rd to August 9th. And we focused at that time measuring respondents' attitudes again towards social distancing after it had become kind of common culture and things had changed, and wearing masks again at that time. We also examined ag and natural resource leaders' opinions around that same time as the first survey, examined 225 leaders in ag and natural resources to determine their knowledge, response, concerns, and beliefs associated with COVID-19. We have done webinars and issue guides and reports for all of this past data collection, and those are available at picenter.com/COVID-19. But the data we're going to talk about today is what we are calling Public Opinion Survey number 4. And I'm going to let Shelley talk a little bit, or rather Dr. Rampold talk a little bit about what was going on when we launched that survey.
Thank you, Dr. Baker. So considering, the rapid pace at which some of these events have occurred and changed throughout the course of COVID-19, it's important for us to first take a look at what was going on around the time that we collected this data. So the PI Center launched this survey January 8th, and we concluded our data collection on January 21st. During that time, the CDC had reported 25 million doses of both, meaning Pfizer and Moderna vaccines, had been distributed. The Trump administration sought to speed up vaccine delivery to people 65 or older. But during that time, the US had surpassed 23 million cases. And then turning with the next administration, Biden had announced his plan to administer vaccines and signed 10 executive orders related to vaccine distribution. Some other key events were the FDA issuing emergency use authorization for Pfizer and Moderna vaccines, and the state of Florida announcing a pre-registration system for vaccines among priority populations. So as you can see, around this time, there was a lot of vaccine focus and a lot of vaccine efforts going on around that time that we conducted this survey. And I will let Dr. Baker tell you a bit about our methods and preliminary findings.
Yes, so this survey matched very similarly to the other public opinion surveys. The we conducted at the Pi Center. We distributed an online survey questionnaire that was developed by UFIFIS, our Pi Center here, which at the time included Shelley Rampold and myself, as well as our entire team. We collected data January 8th through the 21st of 2021. So very beginning of 2021, through a third-party recruiting company called Qualtrics. We had 1,549 participants nationwide, and we sampled for characteristics to match the US Census, which was the 2019 census. At that point in time, that was all that was available. So with that, I'm going to dig in a little bit more on the findings and implications. In this front part, I want to give you a little bit of a background, remembering what Dr. Rampold shared about this time period. It was in early January. And so access to the vaccine looked a little bit different than it does right now. And so each state rolled it out a little bit differently, but many of the people were not able to get the vaccine yet if they didn't fall into a high risk category or something like that. So at that point in time, though, 74.6% of the people who took our survey said that they had made a decision about whether they would get the vaccine or not when it was available to them. And 12.8% said they had already received the COVID-19 vaccine. So just a little bit of context as we start talking about the results. With that, I'm going to get into some of the influencers. And this section that I'm going to talk about of the results, we really went into thinking about the principles of community-based social marketing. And we wanted to understand how people were making decisions within their communities and what the major influencers of those decisions were. So we pulled out some of the top ones here of major influencers. 68.5% either agreed or strongly agreed that medical risks would be an influencer of their decisions. 66.8% said that concerns about unknown long-term risks would impact their decision. And 64.1% said their level of trust in pharmaceutical companies would impact their decision. We've also pulled out a few other motivators or incentives for people to get the vaccine that would be important to them. So these weren't quite as high as the ones on the past slide, but they did come out as motivators or incentives. So recommendations for this from the CDC were important. Reactions and testimonials of others who've received the vaccine were motivators. Recommendations from the World Health Organization, and having insurance pay 100% of the cost. On the next slide, it is important to note that all of these influencers were rated fairly high, but these were the less influential ones for people. So those were getting a gift card to a store for getting the vaccine, recommendations by the President of the United States, and having the vaccine available at my place of work. Now I'm going to turn it back to Dr. Rampold to explain about intentions related to the vaccine.
Thank you, Dr. Baker. So we wanted to examine a bit further why people may or may not want or intend to get a COVID-19 vaccine. And to do that, we looked at that inclination to get the vaccine as an intention. So we essentially asked them to indicate their agreement with, I intend to get the COVID-19 vaccine when it is available to me. And while the findings were a bit of a mixed bag, we did see that more than half of the people surveyed agreed to some degree that they do intend to get the COVID-19 vaccine. However, we still had roughly a fourth of those sampled disagree to some extent, and about 12% who appeared to be undecided or neutral. So when we looked at relationships between some of the factors to explain this, we found that people who had a greater intention to get the COVID vaccine were also those who had more favorable general attitudes, their just general attitude toward the COVID vaccine, held a stronger belief that others who were important to them thought they should get the vaccine, had a stronger desire to actually do what those other people wanted them to do, and then had higher levels of trust in science or scientists in general. So now we're going to take a look at some of those descriptive findings for some of those factors, and we'll start with attitudes. So for attitudes, we saw overall fairly favorable attitudes toward the COVID-19 vaccines. People believed that they were good, useful, wise, and beneficial. And when we looked at the mean scores, we found that they were less convinced that the vaccine was safe. So we should also note that when we look at the range of responses that we had, people who believed the vaccines were useful or safe as possible, we also had people on the other end who believed the vaccines were completely useless, harmful, or dangerous. And I know that we look at this data as an entire sample, but with something like vaccine distribution that requires participation of individual members of a herd, it's important that we do look at the range of our responses and those answering at the extreme ends of the scale. So then we looked at their social norms, or what they think others expect of them. And we found this was another important finding regarding their intentions to get the vaccine. When we asked respondents if they thought select others felt they should get the vaccine, 3/4 of our respondents agreed to some degree that health organizations, healthcare professionals thought they should get the vaccine. And a little more than half agreed that their family members, friends, and colleagues thought that they should get the vaccine. So now it may not mean much if you think someone wants you to do something, but don't care at all about doing what those other people want you to do, right? So when we asked our respondents if they want to do what select others want them to do when it comes to getting the COVID vaccine. So while we saw that over 50% of respondents agreed that their friends and colleagues thought they should get it, less than 50% agreed that they actually wanted to do what their friends or colleagues thought they should do. And so findings like these help us better understand the weight that others might play in shaping people's intentions or ultimately their behaviors in getting the COVID-19 vaccine. And then lastly, to help alleviate some barriers to people getting the COVID vaccine, we needed to first identify what some of those barriers were. While this was not directly related to respondents' intention to get a COVID vaccine, these factors may still be influential in that step between their intentions and then them actually going and getting the vaccine. So what this tells us going forward is that, a task among healthcare professionals, communicators, et cetera, will be to alleviate concerns about potential risks, associated costs, and factors like insurance coverage concerns. And then, of course, we still have to pay attention to this percentage of people who indicated a lack of ability to get to a doctor or a lack of time to do so. And because these are logistical concerns, these may be a bit easier to address than shaping people's beliefs or values or social norms. And now I will turn this back over to Dr. Baker to talk about trust in science findings.
One of the things we've continued to find fascinating throughout this pandemic is how people's trust in science has grown in some cases and lessened in other cases. So particularly when we're discussing their willingness to get a vaccine, we wanted to see what they thought about science and whether they trusted science. So some of those initial questions that we asked were related to, do people trust scientists and science? And Shelley, if you'll advance to the next slide, please. Here we go. So the highest beliefs related or trust related to science were, I trust that scientists are being honest in their work, which 66.9% either agreed or strongly agreed. As Dr. Rampold said, with some of our other data, this is high. And so we do look at this overall and think, well, it's pretty good that almost 70% of people trust that scientists are being honest in their work. But that does mean that, almost, between 30 and 40% people didn't trust that scientists are being honest in their work. So the more we can understand some of our communities and where they feel about trust in science, the more valuable this data will be for interpreting for specific communities. The next highest one there was I was still talking about them. Yeah. I trust that scientists are being ethical in their work. And again, same scenario, pretty high percentages overall. And the third highest there was, I trust the work of scientists. So now if we can look at trust in a different way on the next slide, really looking at trust in science beliefs. So believing that scientists make life better for people, had a high mean there on the top left. I trust the work of scientists, again was pretty high. If you look at these, the green is strongly agree, to the blue strongly disagree. Next, I trust that scientists are being ethical in their work. I trust scientists to share their discoveries, even if they do not like their findings. Some of the other ones here on the right that I've pulled out are: we can trust science to find answers that explain the natural world. When scientists change their mind about scientific idea, it diminishes my trust in their work, which this is interesting, right? Because we have been watching science happen in real time. And so it has looked like scientists changed their mind about how COVID-19 spread, whether masks were valuable, whether social distancing was valuable. That distance changed over time. So as we've seen science play out in real life, these are important considerations for whether people are going to trust science long term. And if you look at these bottom two, these are moving much lower mean scores here. We cannot trust science because it moves too slowly, which is something that we've seen work throughout this past year. Scientists do not care if laypersons understand their work, which those of us that are working in science communication, want people to think that we care, because we do care, and that's why we do this work. So certainly some room for science and scientists to continue working on better communication and building up beliefs and trusts related to science in general, and particularly science related to health during this particular crisis. Next, we'd really like to talk about some of the recommendations. So we laid all the data on you, but what do we do with this information moving forward? And as I alluded to, and Dr. Rampold alluded to, we really do need to ask questions within our community to understand whether this matches our community's beliefs, because different communities may have different perspectives. Their networks may look a little bit different. People in this survey indicated that their networks were helping them make vaccine decisions. So we know that those connections they have, whether those are in person or online, within their community, make a difference in whether or not they will get the vaccine. And that trust in science was high overall, but each community will have different perspectives on scientists they trust and scientists they don't trust. They will also have different relationships, perhaps with their extension service. And you'll notice here this graphic on the left-hand side is a way to really share who some of your opinion leaders are on a local level. This vaccine kit that we previewed in one of our last webinars was developed by people at the PI Center who were working with the Southeastern Coastal Ag Safety Center to really use the recommendations from community-based social marketing and from theory of planned behavior to develop resources that you can use when you're having discussions with people and when you're trying to find some of those opinion leaders and help them be vocal, because they may not know how to share this information. So that toolkit is full of a lot of information. We have a link to it at the end. But as we're building recommendations from this, thinking about who those biggest influencers are will also be important. So on the next slide, you will notice that I talked about at the beginning that some of the really important influencers for people were medical risks, long-term and short-term, and trust of pharmaceutical companies. We did not necessarily ask them if these helped them decide to get the vaccine or decide not to get the vaccine. So these rose up in importance, but we suspect that for some people, the medical risks were a reason that they decided to get the vaccine, and vice versa. Some people may be making decisions related to medical risks to not get the vaccine. And the same is true with the trust in pharmaceutical companies. So how can we really think about alleviating these within our community? Well, we can demonstrate the safety of the vaccine, again, showing graphics of how many people are getting the vaccine and discussing long-term safety of similar vaccines. Because while this vaccine is new, there are other vaccines that we've taken for a long time that have proven effective and have had minimal risks. Visual cues are also an important component of the community-based social marketing, so that people know and have an outward expression of, I got the vaccine, I'm safe. This has worked in favor in some communities and hasn't worked well in other communities. So again, it will be really important within your community to decide who those opinion leaders are that people trust and who they are willing to work with and where those visual cues can be effective. I know at my kids' school, they've sent home information in their folders about the vaccine and why we should get it, and how this can affect our community as well as our children's health. So I've seen some of those things certainly at work. And again, the Ag Safety Centers provided some tools so you don't have to reinvent the wheel as you're implementing these recommendations within your community. And now I'm going to turn it back over to Dr. Rampold to talk about some of those social norms and cues.
So building a bit off of what Dr. Baker just mentioned about identifying opinion leaders and having visual cues in your community and identifying important others, that just further speaks to what we've really found across our data, really from surveys 1, 2, 3, and now in this one, and the importance of social norms and cues. We first saw this when we examined willingness to social distance or willingness to wear a mask. We found that there was a lot of groupthink or social norms or social cues that people were building off of. And we found the same thing with willingness or intention to get a vaccine. So those expectations of what important others or other people who are important to them, referent others, whatever they think that they should do, and then their desire to comply with that has had a big impact on people's behaviors throughout the COVID-19 pandemic. And I think some of us may have observed this, in real time, walking into a grocery store or a gas station, but also on social media. If you might notice that in these echo chambers, people with one set of belief highly influence people around them. Someone important to you says, this vaccine is dangerous. It might impact what you think about the vaccine. And so these are really key for these are really key points for effective communication moving forward. We need to not only figure out how to get messages out to the entire community, but how do we get messages into subsets of those communities, into different groups that have different beliefs and values that are building off of the others. And that goes, both ways. How do we support those with positive beliefs about this, and how do we alleviate concerns among those with less positive beliefs or feelings about the vaccine? And then, of course, another something else that we really want to do moving forward, once we've collected all this data, looking across the different iterations of the survey, is especially considering the groups that we serve, we really need to look at how those social norms or cues differ in rural and urban communities. That also includes other factors that are driving their decision. That could include accessibility, especially in rural areas, accessibility and time. So while with this national survey with people across different areas, we saw that lack of time or time to get to a doctor or access to a doctor wasn't, compared to the others, wasn't as high of a barrier. That might be different if we look at this in a rural area compared to an urban area. And the same goes for information access or seeking behaviors or sharing behaviors. So that's something I think the PI Center would like to do moving forward, is to take a look at how some of these things differ in rural and urban communities and how we can best get into both communities and support people in those areas as best as possible.
All right. And I think with that, that will conclude the presentation of the webinar today. We do have several minutes for any questions that individuals may have. So feel free to begin typing those into the chat box. We do have one question for the panelists. I'll go ahead and read this to the two of you. The question is there a quantified metric that shows how much people rely on social media platforms such as Facebook and others to form their opinion about getting vaccinated or their opinion about vaccines in general?
That is not something we ask in this iteration of this survey. On our very first survey in March of 2020, we did ask about information sources and their consumption behaviors as well as their sharing behaviors. So no, I haven't seen anything quantified yet on how much people are relying on social media to make those vaccine decisions in particular. The next phase of this research for the PI Center is in July. We are going to launch what we hope is a final COVID-19 survey. And in that one, we do intend to ask about information sources again, and should be able to at least quantify how that tracks with people's decision-making related to vaccines. Certainly since we've collected this data in early January, a lot has happened in the world of vaccines related to new vaccines on the market, some of them being taken off, and public health concerns related to that. So I think it will be important for us to ask about the role of social media, but that wasn't something that was within the scope of this particular data set.
Okay. I don't see any other chat comments right now. Or is there anything else, Dr. Rampold and Baker, from the data that or observations, as you were just mentioning right now, Laurie, about new directions based on what you found and where things are going, and where things currently are with vaccines and vaccine hesitancy?
There is something that I forgot to mention that I think is important moving forward, especially with a topic as important as vaccine distribution in a pandemic. Is, you know, a lot of time in social sciences, we look at something and say, oh, well, 80% of the population felt this way and only 20% felt this way. And while it's always important to not ignore that 20%, it's especially important when making recommendations to not overlook that 20% when it comes to vaccine distribution, because that 20% is a large piece of someone's community. And so I think in making recommendations and analyzing some of this data, it's really important for us as social scientists and communicators to look at those on the fringe, what we might consider the fringe sometime. And so I think that makes it a unique challenge going forward and looking at those smaller subsets of the population. So that's something that I wanted to mention and had forgotten to as I was going through the slides.
Okay, great.
That's an excellent point. And I might add, I forgot to mention that in our next survey, we also intend to purposefully sample enough rural audiences so that we can make some comparisons between rural and urban audiences. I think anecdotally, those of us who work in agriculture and even those of us who are general consumers of media right now have seen that there are some differences in how rural communities and urban communities are responding to COVID-19, how they're responding to vaccines. And so we don't have enough data points to directly compare rural and urban within this current data set, but that is something that we're looking to do in the next iteration of the survey. So we're learning and growing as we complete survey after survey in this process.
Okay, we have several comments and questions coming in right now, so I'll go ahead and read through those as in the order that they came in. Question is, any communication strategy recommendations based on data to best address misinformation regarding health and safety? Anybody want to take that about communication strategies?
Well, that's a huge question. And we could probably be here all day talking about that. But I think the things that we really have in the data that can point to a communication strategy do rely on principles of previous theories that we've seen at work within this data. So we've talked about community-based social marketing, and some of those principles there really are finding out what people's barriers are and eliminating those barriers for them, which is why we ask about barriers in this, but also providing incentives. So those incentives may look a little bit different within your community, but as you're building a communication strategy, if you can work with your local community to decide what incentives really will work and who are the people within that community that they're listening to, because that's how GRASS communication works best, is finding those influencers and helping them do the work for you. Often, even though trust in science was pretty high in this, scientists can sometimes still be seen as maybe not that fun, research-based, handing you a lot of data, but not interpreting it. Whereas some of your opinion leaders can really provide personal perspectives of why they made decisions. And they likely will have more influence on your audience because they're members of the community as well. And they're seen as people that they've trusted for a long time, not just people that have kind of risen to fame because of this current pandemic. So I would say, related to strategy, basing on those principles, this data certainly supports continuing to use those community-based social marketing principles.
I'm going to tack on a little bit to what Dr. Baker said and reiterate the importance of opinion leaders in this. That's especially true because we have really found across the surveys just a mix of trust of information. So we're really in a time where people seem to be mistrusting of information in general, regardless of the source. We haven't seen a lot of patterns. There's a lot of questioning of what news is real or fake. And so opinion leaders, real humans, have seemed to be even more important than ever right now going forward and sharing that information. So if it comes from someone in the community that they trust and have similar beliefs and values with in other areas, then if we can get factual information out through those people, it seems to be more likely to be received well by those that value and respect that individual. So I wanted to add that on to what Dr. Baker said of identifying those opinion leaders and utilizing them as pillars of the community and ways of getting information out. That is, we can get the information out there, but getting it out to where it's trusted and received well.
Okay, great. One other question came up with this, asking your data seems to show a pretty high trust in science and vaccine science. It seems in this person's area back in Palm Beach County that I hear a lot of chatter that's anti-science, distrust of the whole system. Maybe this faction is just the loudest, so I notice it more. It's kind of a question mark.
Go ahead, Dr. Baker, you want to take it?
Well, I was just going to say, I think that's something fascinating that we've seen throughout these surveys. This was the fourth of the public opinion surveys. And when we ask about things like willingness to social distance, ability to social distance, willingness to wear a mask, ability to wear a mask, and again, you saw it in this data too, is that the vast majority of people were willing to do these behaviors. Trusted scientists were willing to engage in preventative measures, but certainly the things we've seen in the media have highlighted some of those who don't trust science or don't trust the system and are against masking and against social distancing and feel like those things are preventing their civil liberties. So we have discussed regularly what this means. If people are presenting their best self in a survey, and for the most part, they are willing to do those things, they are able to do those things, but we don't live day to day always as our best selves. So there may be some of that happening. But those groups are also louder. I think you're correct. So you notice them more. But it also may be some of these differences in groups. When we're talking about the population as a whole, we can see these behaviors where the majority of people are. But as both Dr. Rampold and I pointed out in our different sections, it's not a real small percentage of people who said they were distrustful of science. Often around 30 or 40% said, I don't trust what they're doing. I don't like when they change their mind. I believe they don't have my best interest at heart. So not only may those groups be louder, that also it is not 0% of the population by any means who are holding those beliefs. So the more we can get to them through these community-based behaviors, the more effective I think we will be.
We also need to, we also might need to put in some thought or some work into the type of scientists or science that we're trying to gather information on. You know, this round of data collection, we were intentionally trying to measure science in general, scientists in general, but there may be some disconnect between what the public views as science or scientists versus who they view as behind the COVID vaccine. So do they view Dr. Fauci as a scientist or a political figure? Do they view vaccine development as science or as pharmaceutical company, investments? So it kind of, there may be some disconnect between what they traditionally view as science versus what's happening now. And I think that's something, like Dr. Baker said, this was a fascinating finding for us because like you, we've seen a lot of distrust in science and in community conversations on social media, et cetera. And then we saw self-reported high trust in science. So I think there's a lot of exploration to do to help explain that.
Okay. This is the last question that we have. So if you do have another question, please feel free to type it into the chat. This question asks, did the survey consider differences between minority groups, or I would also say underrepresented groups?
Well,
Yes. Go ahead, Dr. Baker.
I'll just talk generally about the sampling, and then I think Dr. Rampold ran some data that we could talk about briefly, but we didn't sample specifically for underrepresented groups. We sampled for groups that were representative of the US population. So that means that we didn't necessarily have enough people in any one minority category to compare equally against the general population. So we're hesitant to talk about differences in a real impactful way without purposely sampling for those pieces. But we did notice some differences in groups, and perhaps that's what Dr. Rampold was going to say. I'll let her talk about that, and then if not, I can come back and follow up.
Yes, we probably will have to. I don't have all of that up with me there. I can say that, like Dr. Baker said, we have those variables in there, so we are able to look at some of these things by, we looked at it by ethnicity, race. We even went as far as to look at it by religious affiliation, income, education. And we didn't see a lot, we really didn't see a lot of differences, but like Dr. Baker was saying, I don't think we have big enough groups because of the way we sampled to really speak to that. So we could talk about those findings, but I'm not really sure they wouldn't be accurate. They wouldn't be as accurate as if we had intentionally sampled to make sure we had large enough groups for those comparisons. So that might be something we do moving forward, but in this one, it's a little bit anecdotal to speak to that.